Welcome to the Innovators session where 8 presenters will each speak for 10 minutes only. Okay, there is your challenge, presenters. This stream, called Creating Partnerships, focuses on showcasing a wide array of partnerships forged between oral health and specific groups or communities to facilitate better oral health. Each presenter will have their contact details up at the end of the presentation and is available to talk to anyone who would like to replicate their program in another workplace, which is terrific. Okay, so first up, partnership with primary schools, Banyule. We're going to hear from Alison and Navdeep. 10 minutes. Are we sitting just
now? How am I moving this? Just that one. Hi, and thank you for having us come and speak. I'm going to talk today just about a partnership with our local primary schools. And there was a couple of things about the program. It was, we thought, quite a win-win-win for us in the local area. We were using a targeted dental screening program with a whole-of-school oral health promotion approach that worked with students, worked with parents and worked with teachers. It was also a service access initiative for disadvantaged schools. So one of the things that we noticed at our service was that our appointments for school-aged children were not being utilised, and we knew that we had a number of disadvantaged schools in the area. One of the things with Banyule is that Banyule's, where Banyule Community Health is situated is right in the heart of the Olympic Village in West Heidelberg, and there are a number of schools and parts of that community that have a low socioeconomic index measure. And some of those schools definitely have a mix of community members who live with particular vulnerabilities. So we were aware that those schools weren't accessing our service in terms of their dental care, but also in terms of their oral health education. So what we did with this program was used a health promotion approach. So we're working with the principals from the Ottawa Charter, looking to reorient our service. And really that was a very proactive outreach engagement with schools that we knew had students of need. We wanted to create a supportive environment, not just go in and screen, but make sure that the environment where the kids were being screened and then being offered dental services would also have an opportunity to be educated, both in the classroom and at home. We wanted to make sure that we developed the students, the teachers and the parents' oral health skills and their knowledge. We wanted to strengthen the school-wide action and make sure that it wasn't just a go in, do a screen, go out, but that it was integrated across the whole community. And where we had a chance, we wanted to make sure that we could work with the schools to strengthen their oral health policy. So a lot of schools we knew had a response to tooth trauma, and so they would have a policy around Save the Tooth, but they hadn't extended into good oral health care. So getting started, we had some of the schools start requesting the screening service to come out to their schools. So they knew that some of their kids were not getting good oral health education, and they knew they weren't getting dental health care. So they had contacted us and said, we think some of our kids are really vulnerable and missing out. We had an opportunity with a graduate dental oral health therapist coming in who needed to do a project. And we had a health promotion team who was working predominantly in the primary schools in the area. And we saw an opportunity for bringing those two teams together with the work of the graduate dental therapist in her project to actually build something more integrated. It required us developing a health education program that could go curriculum-wide across the whole school. So the people that were involved were the dental team obviously going out and doing the screenings, the dental clinic coordinator who needed to do a lot of the timetabling of when the clinicians would be available, make sure that we could match that with the schools and when the schools could fit us in. We had the health promotion team who were doing a lot of the school contact and development of the forms, the assessment forms, the screening forms to start the process, the consent forms, and also starting to develop the education package that they were taking out. Things, little advertising in schools, newsletters, that sort of thing, so that was all easy and packaged up and could be repeated. Obviously the school communities were involved. It was an engagement process and the intention was very much to engage families, parents and children who may not have known about public dental health in their area, might not have known about how to access those services and didn't know about how to provide good oral health education to their children. So what were the surprises? We found a couple of things. When we went out to the schools, parents were really confused about who's who in the zoo, and a lot of that was to do with the public-private knowledge and understanding of our dental health system. There are a lot of private dental services that were going out offering free screenings. It wasn't always clear to the parents that that might then lead to a referral and that there might be fees associated with that. So that was just one of those things about starting to educate and re-educate the community about public dental services for the appropriate communities. We also were working with vulnerable groups who didn't understand the Australian public dental health system at all. So we have a lot of refugees, asylum seekers in the area. They were really unaware and unfamiliar with the Australian dental public health system. So going out into the school where their kids were supported, where the teachers were supported, where the information that was going back home was all consistent was a really, really useful way of engaging them in our service. One of the other surprises was that the kinder program, so the Smiles for Miles that we had been running across the community for a number of years, we were starting to see a benefit from that. So what the team came back saying was that the upper primary school kids who had not been exposed to the Smiles for Miles program had much less oral health knowledge than the kids who had been coming through, had done some work in the kinder program and were coming into primary school. So that was just a great bonus to know, because we'd been running that Smiles for Miles for a little while. It's great to see that it was having an impact. It meant we could then build on that in the classroom work that the health promotion staff were doing. They could build on that work. So in terms of building capacity, we did a couple of different things. We made sure that every school got a report card. It had some general oral health information that went back with them, but also gave them the specific measures of the number of, some specific measures around their oral health and the oral health of the students that they saw, how much decay they found, etc. So they could see exactly where their school community was at. We did that both for the teachers and the school council, etc., but also for the parents, so the parents could see where their school sat. We developed an integrated curriculum so that teachers could take some of the messaging around oral health into their activities around literacy and numeracy, etc., and keep that message consistently for the period of time that we were running the program. And finally, we did an oral health audit to assist schools to identify where they could strengthen their oral health policy. So that was a way of starting to alert them that there could be more in their oral health policy than just tooth trauma. It could go to looking at the food they might have in their canteens, the drinks they might have available, the water fountains they might have, etc., and the messaging they might do. So over a 2-year period, we had 18 primary schools in Banyule who used the program. 3,397 students were participating in the oral health education. 1,280 students were screened, had their dental screening. Of the ones that were screened and who had some decay or other anomaly, 95% of them booked a visit. We increased our service utilisation and knowledge of other Banyule community health services. So once people came into the community health service, they not only got to see a dentist and have the issues dealt with, but they got to see that there are other services that may be of value to them. Particularly remembering, if you were not familiar with the Australian public dental system, you may not be familiar with the Australian healthcare system. Increased staff morale, because there's a real sense that this was a connected, joined up piece of work that meant that not only were they going out and screening and getting a little bit of a message across, it was actually having an impact on people coming back and getting good oral health care. And the dentist said that when a child came in to get their decay looked at, or whatever the anomaly was that they'd found, that they weren't only teaching one child that oral health care and good oral hygiene message, they were able to teach the whole family. So they felt that that was a real strengthener for them, and they were definitely staff feeling very good about that. So our next steps, in fact, is to focus on sugary drinks. So there is a national campaign around sugary drinks that has been, people may be aware of that. We have a number of services, both council and community health, who are wanting to focus in our region on sugary drinks. It aligns really, really strongly with our oral health screening and health promotion campaign, and it still aligns with the Ottawa Charter. So we're going to have national consistency for our public health policy. We're going to have consistency for our community action across the region, consistent messaging to kids, to families, and to adults around sugary drinks, and we are going to continue to create that supportive environment by having specific school oral health policies and procedures. And I think that's time to go, so thank you for having me.
Thank you, Alison and Navdeep.
It doesn't matter, we had the contact details, we didn't do the last bit.
The last slide. Okay. People can find you, though, in the room if they'd like more information. Thank you. Good timing, lovely work. You've set the tone for the rest of the session. Next, we're going to hear from Maria, who's from the Pearly Whites program in North Richmond. Welcome, Maria. Here she comes.
Good afternoon, everyone. My name is Maria, a hygienist at North Richmond Community Health and a team member and a volunteer of the Pearly Whites Aged Care Program. Pearly Whites is an aged care oral health program developed by North Richmond Community Health. It's spearheaded by Dr. Martin Hall, delivering oral health care to residents of the aged care facilities in the northwest of Melbourne. And that's our team. In December 2016, the Australian Bureau of Statistics reported a rapid increase in the population aged 65 and 85 years and over. And by the year 2101, these age groups will reach 11 to 18 million and 5.5 million respectively. The Australian Institute of Health and Welfare in 2015 also reported an increase in the DMF, periodontal disease, tooth loss and denture use among these age groups, and older people are more dependent on their carers in terms of personal care and hygiene. Therefore, maintaining oral health can be difficult, particularly in institutionalized older people who are medically compromised, have cognitive and physical impairment. The aim of Pearly Whites reflects the current FDI's definition of oral health, which is maintaining oral functions such as speech, deglutition, mastication, and taste, with the absence, of course, of pain and discomfort, and that oral health does not occur in isolation, but is a part of a person's general health, which are all essential for an enhanced quality of life. Our program's objectives are, first, is to maintain the oral health of residents to enhance their quality of life, to increase oral health literacy by providing oral health education to staff and oral hygiene instructions to residents and through their carers, root stumps, arrested caries, and tooth mobility are few of the common findings among older people. Our program focuses on the residents' oral comfort and function. So if treatment is unavoidable, referral to North Richmond Dental Clinic, the domiciliary care at the dental hospital, and at private dental clinics will be provided. We also aim at assisting aged care facilities in meeting their accreditation needs, and for the program, of course, to be maintained for long term. Pearly Whites will not eventuate if not for the efforts of the primary health network of the Northwestern Melbourne, who works to provide aged care facilities access to healthcare services and coordinate with different allied health professionals. The different aged care facilities, their staff, the residents and their families, the North Richmond Community Health, the Pearly Whites team headed by Dr. Martin Hall, our senior dentist, Dr. Kavita, team of dental hygienists, Anna and Vang, and our oral health educator, Lulu. Our program is delivered by our team in cooperation with the facility staff and carers, which involves 3 to 4 sessions, using simple equipment such as the portable trolley carrying the laptop, the headlight, silver fluoride, PPE, gauze, varnish, chlorhexidine mouth rinse, denture reline material, and the portable X-ray. During our first visit, we introduced the program to the facility. We provide information pack containing the program's screening sheets, report forms, and certificates. If the facility agrees to participate in the program, the consent forms will be obtained and initial assessment visits will be booked. On the second visit, hygienists conduct oral health assessment, which takes about 3 to 5 minutes per resident, but the number of visits depends on the number of consents from the facility. An individual oral health assessment report will be provided to each resident, and like a general facility report will be given to the facility at the end of the initial visit or initial follow-up assessments. And on the third visit, our oral health educator provides education workshops with the facility staff. They complete a 16-item oral health questionnaire before and after the session. It contains questions about oral hygiene, dental care, saliva, and plaque. And on the last visit, we do follow-up assessments to review and assess changes in the residents' oral health. In the past 2 to 3 years of Pearly Whites, we have seen good relationships established between our team, the facility staff, and the residents. The families of the residents acknowledge and express awareness and show importance in the residents' oral health. More and more staff show interest during education sessions. They get more engaged, interactive, and ask relevant questions. And during our follow-up visit assessments, we unexpectedly receive news that some of the residents, which we have seen during our initial assessments, have died, or that they have been transferred to another facility. Our team also encounters different sorts of challenges. One is some facility decline participation, while residents refuse to open their mouth and decline assessments. We also get low consents from the facility, or sometimes we are unable to get the consent on the appointed day, and low number of staff attending the sessions. There are also new staff in the facility taking over a new role who are not aware of our program. And also we encounter difficulties in assessing the oral health care of residents with dementia, as most of the time, the staff are unable to assist us when we do assessments with them. And communication, like for those residents who prefer to speak their own language and no one is available to interpret for us. Pearly Whites uses this tool, the Modified Kaiser-Jones Oral Health Assessment Tool, which has 8 categories, assessed as healthy, which has a score of 0, changes 1, and unhealthy 2. We also assess the residents' gingival conditions by using the Modified Gingival Index and the Oral Health Related Quality of Life Questionnaire to identify the residents' satisfaction of their own oral health and the importance they give to oral health and their functional status. We also show smiley faces sad faces and unsatisfied faces to residents and ask them to pick one which will describe their experience with us. In the past year, we assessed the oral health literacy of the staff who participated in OHE sessions. So 13 aged care facilities completed the workshops, 127 staff participated. And this is just a summary, the graph summary. So the green bars represents the pre-education scores of staff, comparing the blue bars, which are their scores after the session. And upon evaluation, it shows that the facility staff had a pre-workshop average of 11 out of 16 items with a percentage of 69%. And after the session, like completing the questionnaires after the session, they got an average score of 14 out of 16 with a percentage of 88 to 90%. So what's next for our program? Currently, we are conducting a pilot study with the help of Professor Rodrigo Marino of the University of Melbourne on the plaque removal device created by the APS Innovations Company. So this device was developed for people with manual dexterity issues who are unable to use the toothbrush properly. And our program is looking at including this PRD device in the future to be included in the oral health pack to be provided to the residents in different aged care facilities. With simplicity and serviceable way of delivering oral health care to residents, the program can be easily executed to different agencies, particularly if we tailor the program around the facility staff convenience and also the residents. And these are all essential in the success and sustainability of our program. In behalf of the Pearly Whites team and the North Richmond Community Health, I thank you for sparing your time with us as we showcase to you our program.
Thank you, Maria. Now, don't go. And to Alison and Navdeep, I forgot to present you with a gift. I'll find you at afternoon tea. There you go. Thank you. Well done. Thanks, Maria. Now, Pearly from Monash is going to talk about integrating oral health services into community life. Welcome, Pearly. There you are.
Good afternoon, everyone. Better oral health for all is a destination we are all heading towards, but the road to our destination is under construction, and we all are forced to go slow due to environmental, physical, social, and physical factors that impact the oral health of individuals. However, we all innovate every day to speed up our journey, and today I'm going to give you all a snapshot of all the various innovative steps that we take at Monash Health to eliminate these barriers. Oral health promotion, which is one of the 6 foundation areas in the Australian National Oral Health Plan, and which according to the plan can help in improving the oral health of majority of Australians, is the main ingredient in all our successful programs. And this sentence, taken straight from the plan, is pretty much a summary of what we do at Monash Health. A coordinated and collaborative approach using multiple strategies. There is no single strategy that I can give you to take back to your agencies. It's always a combination of strategies that has worked for us. But we do have a framework that we use for our oral health promotion programs. And it is the Victorian Integrated Health Promotion Framework. And using this framework, we integrate oral health into the lifespan of our community through a range of strategies, including screenings, health education, creating supportive environments, and many more. And for these multiple strategies to work, we need a collaborative approach. And that's another area that we excel in at Monash Health. These are just a few organizations that we work in partnership with. And these organizations have experts in various fields. And all we do is utilize their strengths to improve and amplify our strategies for the benefit of our clients. Our health promotion program targets a range of audience, which mainly include our priority clients. And the first one on the list are children. Poor child oral health is a significant problem in the southern metropolitan region. And to tackle this fast-spreading issue, a range of strategies are used, including partnering with the local schools and local councils. Professional development workshops are conducted for teachers, for educators, for maternal and child health nurses, midwives, visiting primary school nurses, and parents as well. Sometimes we even conduct workshops for parents after hours. Other strategies include school screenings, fluoride varnish applications at schools, and working with the schools to develop an oral health and healthy eating policy. In 2015 and 2016, we screened nearly over 6,000 children in our catchment area. Next on our list are young adults, pregnant women, and our senior citizens. We run community-based preventive programs for expectant and new mothers, as well as young adults across Monash hospitals. And we also participate in festivals for senior community members in our catchment area to screen and educate them. Aboriginal and Torres Strait Islanders are a very important cohort on our radar, and we work very closely with the Aboriginal Health Team and the Dandenong and District Aborigines Cooperative Limited, otherwise known as Aboriginal Co-op, to conduct education sessions and screenings for young children and their parents. Our outreach team visits the local Aboriginal playgroups and also participate in the Back to School Day event to do screening and even to give away toothpaste and toothbrushes to the children participating in the event. World No Tobacco Day is a well-attended event by the Aboriginal community, and our team supports the event by reinforcing the oral health messages, making quick referrals at the event, and even conducting dental checkups for children and parents attending the event. These photos were taken just 2 weeks ago at the fun run on Sunday, the 19th of March. In addition to covering all age groups, we also welcome all cultures and acknowledge the differences that occur in differences in oral health practices that exist within various cultures, especially our refugees and asylum seeker population group. And to get the clients in the dental chair for a checkup, sometimes you have to do what the client wants. As you can see, our oral health therapy students and myself dressed up as Egyptian pharaohs at the Harmony Festival, where we screened nearly 80 people at the festival, including the pharaohs. Plus, we also screen dinosaurs sometimes, as long as they're under the age of 10,000 years, with or without healthcare card, as well as superheroes. It doesn't matter whether you are a Spider-Man or a Batman, you still have to brush your teeth twice daily using fluoride toothpaste. Now I'll briefly talk about a couple of successful programs that we run annually. First one on the list is World Oral Health Day. It's a day for the rest of the world. For us, it's a World Oral Health Week. We celebrate it for the whole week, and we spend a couple of months to plan and prepare for it. And this year's program included screenings for refugees and asylum seekers attending our clinics, screening education session, and oral health themed coloring competition for children at 4 different schools. And you can see some of the great artwork that children's created. And participation at the Harmony Festival, celebrating the multiculturalism and diversity in the city of Greater Dandenong. Screening sessions for Aboriginal community at the Fun Run. Moreover, this year we also trained Monash Health volunteers who are from refugees and asylum seeker background to deliver oral health messages to pediatric patients attending Refugee Health and Wellbeing Clinic at Monash Health. And lastly, but most importantly, we screened and educated heart patients who visited Monash Heart Hospitals. And you can see one of the little boy having his teeth checked by one of our senior clinicians. Dental Health Week is another successful event celebrated annually at Monash Health. And as per the Australian Dental Association theme, in 2016, Monash Health focused on women and oral health and screened more than 500 women in a week, including female Monash Health staff members and pregnant women. And we also conducted dental checkup for children at Monash Children's Hospital or Monash Children's Ward, And the photos on the lower right-hand side shows an oral health information board which was prepared by a nursing unit manager in the children's ward. She also received a Monash Health Eye Care Award for her brilliant effort, a perfect example of a staff that goes above and beyond. We need more oral health champions like her in every department who can do our work for us. And this poster was also developed last year to show the effect of oral health or poor oral health on general health to health professionals from non-dental background working at Monash hospitals. And staff booths were held across major hospitals to educate staff because, as we all know, mouth is not considered as important as heart or lungs. So we have to educate non-oral health professionals that it is equally important and what effect it can have on general health. And the highlight of the event was the dental team visiting the pregnancy care clinics across 3 major hospitals where they provided dental checkup to more than 300 pregnant women in a week. Finally, I'll talk about the Little Day Out Festival is an annual children's festival that Monash Health participates in and screen nearly 300 to 400 children each year at the festival. And this is just one of the examples to show what you can do when you go out to the community. We participate in many similar festivals to screen and educate parents and children in our region. Some take-home messages. It's always been multiple strategies that have worked for us. There is no single strategy. As you can see, we do anything and everything that we can do to promote oral health. We build upon our existing networks to promote oral health in the community, and we get the community involved to be oral health champions for us and do our work for us in the community. And finally, talk to our wonderful Monash Health team. We're sitting right back there, so catch us during the tea break, and we'll be happy to help you replicate the program at your agency. Thank you very much.
Thank you, Pearl. What a festive life you've got.
Yes, we do.
Looks like fun. Yes. Let's see. Try and get the right card. There you go. Well done.
Thank you.
And hello to Monash at the back. Terrific. Thanks, Pearl. Now we're going to hear about integrating Smiles for Miles into the outer east of Melbourne, and Diana from each is going to tell us about that. Welcome, Diana.
So do I just click the side buttons? Yes. Okay. Hi, I'm really excited to be here and I'm really nervous. So I have been involved with Smiles for Miles for 5 years now and I've loved every minute of it. Not only do I get to play a small role in helping to improve the oral health of children in my community, but I also get to work with some amazing and highly dedicated people. So what is Smiles for Miles? Smiles for Miles is a 2-year award program that aims to promote the oral health of preschool-aged children in the community by promoting the 3 key messages of drink well, eat well and clean well. Smiles for Miles focuses primarily in more disadvantaged areas or areas that have been identified as having the highest prevalence of tooth decay. When I was first approached to take over the role of Smiles for Miles coordinator, it was pitched to my manager and myself as just a small project that the health promotion team didn't have time for. At the time, we had 7 early childhood services participating in the Knox Shire. Today, we have 75 early childhood services participating across 3 local government areas, and we're reaching out to just under 5,000 children and their families. Our goal is to work in partnership with both internal and external stakeholders to improve the oral health of children in the community, to increase the number of children accessing the oral health program, and to improve the oral health statistics in our region. In the last 5 years, the number of children accessing the oral health program at each, aged between 0 and 5 years of age, has tripled. Service growth has been steady, with a noticeable increase when Knox Social and Community Health merged with each and we expanded into the east. Statistics released late last year by Dental Health Services Victoria showing the oral health profiles for each local government area clearly show that we're making a difference. The number of children presenting with decayed, missing or filled baby and adult teeth in the Knox region, where most of our work has so far been done, is well below state average. This has been achieved primarily by having strong partnership focus through our work with Knox City Council on their policies, and of course with our dental clinic, all the work through the dental clinic. So the increase in services has not happened overnight. It has been a steady progress. It was no coincidence that in my first 2 years of being involved with Smiles for Miles, I focused on council-run preschools. I did this because of the benefits I could see, such as when it came time to working on their policy, so the policy criteria, which is also one of the trickiest components of the Smiles for Miles program. It was only one policy that I was working on and not how many services I had enrolled at the time. Also, by having council on board, it meant that if there were any changes that needed to be made to a centre's program, that I was less likely to come up against any resistance, as the directive was coming from council as well, not just myself. So my aim is to work smarter and not necessarily harder. So if that's something that you aim for too, then focus on council-run preschools, cluster-managed preschools, large organisations such as Good Start that have multiple sites across the state. Link in with other agencies and services, the Healthy Eating Advisory Service, the Achievement Program, and most importantly, the local dental clinic if you're not fortunate enough, as I am, to have one on site. So our tactics, as the previous speaker said, are many and diverse, and our methodology can quite easily be implemented by anyone. Initially, choose an area that you want to focus on. So this year I chose Maroondah because once again the oral health statistics released last year from DHSV clearly indicated a need for greater oral health promotion in that area. So start with a mail drop, emails, phone conversations. If possible, go out and actually meet the services that you're trying to recruit. I know this isn't always possible because we are quite time poor, but it does help. In the first 2 years of engagement, be prepared to work a lot closer with your services, guiding them through the steps, helping them along the way, reminding them of when documentation is due. But once they get to realise how easy it is to incorporate the 3 key messages of drink well, eat well and clean well into their daily teachings, they pretty much run the program with minimal support and supervision. Of course, being organised is key, so I have lots of templates that I use to help keep me on track, and these templates allow me to see at a glance where each of my services is at and what needs to be done next, and I'm happy to share them with any of you. So surprises, there have been surprises along the way, but I think what surprises me the most is despite reaching out to so many families, many people are still not aware that there is a local dental clinic in their area and that children can access the public dental clinic up until they turn 13 years of age with a healthcare card or pension, with or without a healthcare card or pension concession card, and with or without the child dental benefit schedule, free of charge. There are no waiting lists for children at the public dental clinics, and they are offered the next available appointment. I can't say we've had any disappointments. There are challenges, of course, as I mentioned, the initial intensive phase, that stage that all services go through. But again, once they realise that unconsciously they have really been implementing the Smiles for Miles messages into their program all along, and they just perhaps need to expand on them a little bit, then it's all easy. The feedback that we've had from parents and educators is also indicative of the success that we've had with Smiles for Miles, And this year we're expanding our scope and also offering oral health screenings to all the Smiles for Miles preschools in the hope of capturing even more children. So where to from here? So our aim is to see as many children as we can accessing the oral health program, and that is why we will continue to recruit services each year. We're all working towards a common goal of reducing tooth decay in children, because we know that good oral health contributes to good overall health and well-being, and that children need their teeth in order to eat, speak and socialise without pain or discomfort. I have included my email address. Please feel free to contact me if you'd like more information on implementing the program or any help. Happy to share any of my resources or templates, and happy to help in any way I can. Thank you.
Thanks, Dad. Well done, thank you. That was terrific. Thank you, Diana. Okay. And now we move on to the Children's Dental Project in Plenty Valley, and Tan and Shaibu are going to tell us about that. And here they are. Let's make them welcome.
Well, thank you, Angela, for the introduction. My name is Shibu Matthew, and this is my colleague, Tan. We would like to share our collaborative work, the Children's Dental Program. This work is supported by Plenty Valley Community Health Dental Health Services of Victoria, the Evident Foundation, Melbourne University, and the Australian Dental Association Foundation, and Wrigley Company Foundation. Our work has been presented at various conferences in Australia and overseas. In our dental program, we give emphasis to see more children. Our team felt that many children were receiving dental treatment for severe levels of dental caries that could be avoided. We know from the academic literature that children at high risk for oral disease are not seen by a dental practitioner early enough for disease prevention. In Victoria, there were very limited data on the uptake of dental services by children. In 2012, our organization decided to develop the Children's Dental Program to address this public health issue with a research-based approach. You can see our project's context is located in the outer metropolitan region of Melbourne, highlighted with the yellow star. This location is in a low socio-economic area. I will now let Tan tell us what the evidence says about school-based dental program. Tan.
Thanks, Shibu. I'll flip through the slides. Yeah. Okay, so in terms of the work, we wanted to find out what's happening in the school-based services space, and to find out if screening is the best way to do things through our project that we're looking to do. So what does the evidence tell us about school-based dental screening? A lot of the work has been done in the United Kingdom, because they used to have a policy-based approach to do dental screening in that setting. And what we found is that, and even not only in the UK, but also in the United States, in other areas as well, that there's weak evidence to show that school-based dental screening by itself, in terms of it being beneficial, is weak in terms of the evidence. And that more research now is showing that there's currently no evidence to show whether it's to support it or refute it as a public health intervention. So in terms of what we did in terms of our project is we took a different approach, and we changed how we were looking to do a school-based project. And that included actually arranging an appointment with the child at the school setting, and we needed to have the primary carer as part of that process as well. And so that gave us an opportunity to go through other things, not only just looking at tooth decay, if it's there, but also to go through things around risk assessment, to go things around dietary counselling, and also oral hygiene instructions as well. It took a lot of work, and as what Shibu said is that we did take a research approach to do this project, and we also involved a lot of partners as well. And so we'll just take you through how we developed this project as a collaboration. We identified the partner, obviously being Plenty Valley Community Health is our main partner for this project. We were looking to use it from a research-based approach, so we wanted to include other people to help us develop that research rigour, and that included the Evident Foundation, which is a charity organisation that is developed through the ADAVB, and also the University of Melbourne as well. We had to go through a research ethics process, and as some of you may be aware, that it does take some time to do. And because our public system isn't really funded for prevention, we needed to find some kind of seed funding to help kick this project off. And fundamentally, we also needed a whole organisational approach as well. So Plenty Valley has been very instrumental to help us to develop this project and evaluate it as well. So where are we to from here? These are our early outcomes, and it's a very small group that we started with. We saw about 149 children in the school-based dental checkup program. And as you can see here, in terms of the reach that we've done, that's almost half of the children that we saw had visited dental practice for an assessment. And about a third has been seen more than a year ago. So it tells us that we definitely need to do more outreach programs as well. As part of how we plan things and how we deliver the project, the most important part of what we did is to evaluate what we do. And so obviously things around planning is important. To implement it is quite nice and easy to do, but evaluation helps us to inform whether our project is working or not as well. In terms of the next phase, what we did, because we completed that project in 2014, we decided to look at how we should evaluate it from a health economics perspective. And so this included measuring health outcomes as well as costs in terms of the project. And our work has been recognised at an international level. And this took us to South Korea in Seoul. Our work was recognised for a Colgate Research and Prevention Travel Grant with the International Association for Dental Research. And if those who haven't been to Seoul before or is looking to get some very good congee, I know I'm quite Asian, but this is the place to be. There's a street there that shows where the best place to be for Asian congee. So from here, we're expanding our project now. So we are including Plenty Valley Community Health as the primary site, and we're also looking to replicate this across Peninsular Health as well. And so we're at that next stage where we've started some work at Plenty Valley Community Health. Early work from there for this third phase of the project is that we found about 7 out of 10 children in the intervention group, so children who were receiving a school-based dental checkup needed to come back for dental treatment, compared to about 50% of children who were seen at the dental clinic. So it tells us, yes, both groups, not only from children who've already had a course of care, but also those in the community setting, there's still quite high needs there, and as evident with our intervention that we did choose an area with a low socioeconomic area. And from here, it's starting to develop those grassroots. So we're looking to expand this project, obviously to share our findings as well, and moving forward to also demonstrate more that with a larger sample size, that perhaps a school-based dental checkup program could be useful for broader expansion. And again, just to highlight that it's important to evaluate what we're doing. And so as part of our research approach, we needed to control for confounders, or what would say things that could affect our results. So when we were measuring dental decay rates or dental decay experience, we had considered including fluoride varnish as part of our intervention, but we wanted to check a school-based dental checkup as an intervention first, because we know that fluoride varnish is quite beneficial to help prevent dental caries development and progression, and we wanted to eliminate that as a variable. And so opportunities now is to look at including fluoride varnish in our program. And fundamentally, again, obviously organisational support is important, but also we also need to have a very passionate team as well. And so this included our partners, Plenty Valley Community Health, also the university, and looking to move this forward in 2017. And we'll be roaming around, so if there's any questions, I'm more than happy to take them. Thank you.
Thank you, Tan and Shabu. Don't go. Well done. Thank you. Okay. Moving on, we're now going to hear about providing mobile services across the southwest region, and Corey is going to talk to us about that. Welcome.
Okay, thank you for having me. As you can see, my name's Corey Gripentine, Business Manager of Southwest Regional Dental Services. For you guys who don't know where Warrnambool is located, which is where I'm from, we're at the end of the Great Ocean Road, end of the 12 Apostles, or there's only 8 currently. So this is a little map of our region and Warrnambool, a bit of history from where we've come from and why we have an outreach service. Pre-2007, we had 2 chairs and up to a 6-year wait list. Come 2011, we started an outreach service to Gundi Jamara. They had a chair on site, and Tim Boone. Sorry, someone's ringing me and it's covering my notes. So this is roughly where we'd gone. This geographical area, we're travelling up to an hour just to get to Tim Boone, so we're losing a bit of time each day sending clinicians down the road. In 2014, with collaboration with Western District Health Service and Portland Health, we rolled out a regional model, and we relocated our facility in Warrnambool and took that to Camperdown, and we now have 6 chairs in Warrnambool, 3 chairs in Hamilton, 2 chairs in Portland, and 2 chairs in Camperdown. Okay, 2015, along comes our little dental van, thanks to our DHSV. This travels around from Balmoral, Casterton, Windamara, and Dewek, down in Portland. To give you some perspective, if you wanted to visit all our sites in one road trip, you would allow 6 hours, and that wouldn't get you back home. So it's quite a spread out area. And there it all is. Okay, so the concept was dreamt up by Portland Health and came about in 2015 as part of the Closing Gap initiative to help us get to Aboriginal communities. So it came to fruition in 2015 with support of DHSV, and the main concept was to get to isolated clients, Aboriginal communities, and to give our whole region a 1-hour rule, which meant that everybody in our catchment didn't have to travel more than 1 hour to get access to dental services. What's worked well? Our staff have got to engage with a lot of other clinicians. Our Casterton site is actually at another smaller health service, and we now have a fixed chair there as well. The Balmoral Clinic is at a nursing centre, and Dewek and Windamara are at community centres in Aboriginal communities. So we've engaged with a lot of clinicians, we get a lot of referrals, which works really well. And in our Aboriginal communities, we now have a lot of families coming through regularly with their children. Patients that couldn't get access or couldn't travel now have access to care. Rural Victoria, you get a lot of people who can't, for various reasons, from mobility, health, financial reasons, can't travel. Now they're more likely to pick up care. Staff have loved the cultural diversity and being part of the community in those Aboriginal centres, and have been invited to days they've had and have actually attended to and had some really eye-opening experiences. So it's been really satisfactory for them. Okay, what hasn't worked well? Failed to attends. There's been lots. It's been a really difficult scenario where we've had days where dentists will have 2 appointments and they sit around all day trying to rope people in. Working in some community centres, if we've had people walk through, we'll literally grab them out and bring them in. When's your last oral health check? They have low oral health education in general. The more regional you go, the lower the oral health education is. Follow-up can be difficult. There's not always reception in these areas. You've got people in farming land where they're not around their phone during business hours. They don't have message bank. There's a low investment in overall health and oral health. It's seen to be on the back burner, so it's not a focus of theirs to get it looked at. In the outreach sites, there's a fair bit of staff movement, or there was at the time, which made it difficult for follow-up, follow-through, appointment bookings, communication processes to be in place. When we did get clients in chairs, the sessions, especially in the Aboriginal community centres, were very intense. Not knowing when you'd get them back, we would try and do as much as we can, rather than they have their appointment, examination and a bit of a treatment plan. Would be straight in trying to get as much work as we can done in case you didn't see them come back. Travel time and set-up times. So I mentioned previously about geographically large the area is. When we're sending a van out with a couple of staff to go to a clinic, you're losing a third of your day instantly in travel, set up, pack up and travel back again. So productivity-wise, 2/3 straight up. What are we doing about it now? Engagement. That's the biggest thing. So as I said, Casterton runs out of hospital. They work in the public health sector, so they're very savvy with how other healthcare sectors work, and they follow policy, follow procedures. The community centres, not so much. They don't like the bureaucracy. It's very much person to person, not policy driven, not protocol driven. It's very rapport built, and not something you deal with as much in the public health. So we're engaging a lot more now. One of the CEOs at Windamara actually said to me that when we were talking about seeing the Aboriginal people and how we can engage everyone, and this is one of our new strategies, he said, you've got to get them all or forget them all. And the policy behind his thought with that was, we may see healthcare card holders, and in the breadth of their family, not all of them have that. And if you don't see a family and get a whole family to come and see you, they don't change. There's no better outcomes. So now in those Aboriginal communities, we will see anyone that is part of that community centre, regardless of status, as part of the bigger picture to change, which is starting to actually really show. We're also developing specific focused oral education for elders, nurses, educators in those community centres, and they're now making that a bit of a top of mind knowledge and what they're delivering to their people as they're having sessions, regardless of what those sessions are about. This is some artwork that came up when we rolled out the dental van. We had a bit of a competition with the Aboriginal communities, and this is now on all of our logos as we're going around the region. And fantastic picture. Christy Stockton did this and won a prize for that as well. And we have that on all our banners. That's me.
Thanks, Corey.
No worries.
Just wait a second. Got your compendium.
Thank you.
Thank you, Corey. Nice part of the state where you are. Safe travels back. Now, our next presentation is called A Responsible Mobile Dental Service, and we're going to hear from Kate from Royal Flying Doctors. Welcome, Kate.
Hi everyone. As you heard, I'm Kate Storer. I'm the Program Manager for Flying Doctor Dental Clinic. I'd like to thank Corey for going first because he really set the scene for the mobile services in the area. Thank you. So, the Royal Flying Doctor Service Victoria has been servicing Australia for over 90 years through aeromedical emergency rescue and primary healthcare services. John Flynn founded the Royal Flying Doctor Service using the latest innovation of the time, and we proudly continue that tradition of using innovations to service Victorians across the state. Here in Victoria, we are striving to create a healthier population across all of Victoria, and we are proud to be servicing people like 7-year-old Amelia Rose and Elvina. Today, I'd like to tell you a bit more about Elvina and the chance drive-by that enabled us to visit her community of Wedderburn. Elvina is a resident of Wedderburn, which is a town 2.5 kilometres northwest of Melbourne. Elvina moved to Wedderburn with her husband last year, looking for a more relaxed, affordable lifestyle. Elvina's ageing husband suffers from motor neuron disease, and she is his full-time carer. Elvina is eligible for public dental, however, because she's a full-time carer, she can't afford the time it takes to travel to the nearest public dental clinic. Through the partnership with Dental Health Services Victoria and the Australian Dental Association Victorian branch, we are able to help service people like Elvina. So, how did we come to Wedderburn? I've got a short video here that will hopefully play to give you a bit more of an intro. And it didn't play, so we'll just move on. I thought that might be the case. So if we had watched the video, you would have met this man here, Greg. Greg is the reason that we were able to get to Wedderburn. Greg just happened to drive past our clinic one day driving back to Melbourne as it was driving up to a community. He wrote down the number and gave us a call. Greg is the president of the Wedderburn Developmental Association, and that association identified oral health as a key priority area last year. They tried to recruit a private dentist to operate out of their local hospital, but unfortunately were unsuccessful. Although there is the nearest public dental clinic is 48 kilometres away, for people like Elvina and those who have transport barriers and other barriers such as income, still struggle to get to that service. So, before I tell you a bit more about how we came to the process of coming to Wedderburn, I'd like to tell you a bit more about the community. Wedderburn is mainly a farming community, but back in the day it was full of gold miners and prospectors. Until this day, they are still lucky people that are able to find the odd nugget of gold. There is an eligible population of 916 people, and majority of those are aged between the years of 45 and 85. As I mentioned before, the program works in partnership with DHSV and ADAVB. Therefore, before we were able to come to the community of Wedderburn, it was important for us to engage with our partners to ensure that this community did require the outreach services that we offer. So we talked to DHSV and we found that there was no current outreach services to that community. Then they help us facilitate conversations with the nearest public dental agency, which in this case is Boort District Health. So we had a great conversation with them, and the CEO there was happy for us to provide an outreach service to Wedderburn. We also helped to set up referral pathways back to the fixed clinic for any patients that we couldn't finish their treatment, and also a system of removing patients from the waiting list if we do happen to see them in our clinic. As with any program, there are challenges bringing a new service to a town. For example, without surprise, there was no three-phase power in the community that we could hook our clinic up to. Fortunately, the Developmental Association had the funds to install three-phase power at the local community centre. Other challenges we faced is finding appropriate accommodation for our staff and dealing with equipment breakdowns in the middle of nowhere. But the main challenge we face is engaging those community members that are not currently actively involved in their oral health care. Part of our program is a screening program which goes into the communities before our mobile clinic. This program helps to identify any children in the area that require treatment, and if they do, then we offer them an appointment on our mobile clinic. We also often see if the parents are eligible as well and offer them an appointment, and it's a great way to help engage the whole family in their oral health. So we were in Wedderburn for 2 weeks for our first visit, and we were fully booked, seeing over 40 patients within those 2 weeks. And we received fantastic feedback like, "So happy with my teeth, I can't stop smiling." It was interesting to note that on average, the adults in the population had not been to the dentist in over 6 years. With one particular patient, it was the first time he'd been to the dentist in 47 years. Why are we successful? It's because of our partnerships. It's because we have strong foundations set with DHSV and ADAVV that enables us to be able to go to these communities. We also work in partnership with the local community health services, the nearest public dental clinic, and regional stakeholders. The other important reason that it works is because we have dedicated and enthusiastic staff. I'm very privileged to work with a team that are passionate about rural health and are very resilient problem solvers when the suction unit breaks down for the third time that week. And I'm sorry, I was a slide behind. There is our lovely CEOs. The other reason it works is because of their amazing patients. The feedback that they provide us help us to continually improve and drive to expand our services. So where to next? We are always happy to talk to other providers who are looking at doing mobile services or are currently doing mobile services, and we can always compare notes. Also, if you do know any towns that require outreach services, I encourage you to talk to Dental Health Services and they'll help facilitate the conversations with us. So there's our contact details on the screen there. So if you do have any questions, feel free to send me an email or give me a call.
Thanks, Kate. Thanks, Kate. Okay, and our last speaker in this segment is Felicia from Link, and she's going to talk about working with cancer patients, and here she is. Welcome, Felicia.
Thank you. We've seen a lot of affirmation on the screen at the lunchtime, so my affirmation for today, I'm very grateful to be in the room with so many people who dare to break the boundaries of the healthcare system. This presentation is about the power of an idea. It is about thinking outside the square on how we can bring value from our dental clinics for a better outcome for the patients. It is about not being afraid to be inconvenienced, to go through the pains of professional growth, and ultimately it is about giving our skills for the good of other people, and in this case for the good of the people with cancer. At the time of a person is diagnosed with cancer, usually they have a list of other healthcare issues, and mouth issues is a big one of them. Unfortunately, the healthcare systems, the hospital systems, don't have a lot of capacity to deal with all the mouth problems. So when a person is diagnosed with cancer, they are labeled as a patient, and they start a journey through the healthcare system that is frequently broken, and not often they can find relief for their pain. The mouth and teeth problems are usually treated in siloed healthcare institutions, such as our public dental clinics or private clinics. Many times the patients and the hospital staff don't know about. And this is something that also was raised by Pearly in his presentation. So it is fair to say that the cancer patients in need of oral health care are actually falling through the healthcare system cracks. Oral health is a prerequisite for the treatment of some types of cancer. And we do know that during cancer therapies, oral health can rapidly decline due to the side effects of the medication, sometimes just the patient neglecting their oral health. Mucositis is one of the dreadful conditions that actually can cause a lot of pain and can be very debilitating for the patients and really affect their well-being. So what we do when these patients present to our clinics, many times we label them as difficult patients. We usually put them in the too hard basket and we refer them oral medicine specialists, special needs, or oral surgeons. Sorry. So one day at Link Health and Community, on just a normal corridor conversation, we raised the issue of the cancer patients' access to timely oral health care. We thought about the alternatives they have for treatment. We thought about their eligibility for our public or private dental clinics. And then we came up with this idea that, hey, Moorabbin Cancer Centre is actually just 5 minutes down the road. So, bingo, we had an idea. Let's create a referral pathway for the cancer patients. I would like to acknowledge the power of corridor conversations because they are great avenues that spark creativity. This is where people engage in, conversations where they are not afraid to be wrong, they are not afraid to be judged or criticized. And frankly, at Link Health and Community, most of our brilliant programs are originated from corridor conversations, so I highly recommend them. So we set a goal to provide high quality and timely oral health care to all cancer patients that are screened at Moorabbin Cancer Centre. We also wanted to be able to provide palliative and emergency care during cancer therapies for these patients, and we really wanted to expand our intervention and integrate these people in the healthcare system more broadly by linking them in other healthcare services upon dismissal from the hospital. So what did it take? It's not easy to create a referral pathway. We were lucky and blessed to have a very dedicated group of clinical and administrative staff. Our receptionists were fantastic to actually prioritize this activity. Now, every time you want to break the boundaries with another healthcare institution, one little tip is that you want to identify a shared interest. When you have a shared interest, it's a very powerful driver that actually motivates people to go through the change. There are lots of difficulties, as you will see along the way, and this shared interest will probably be the secret to make the project successful. When you do anything like this, you must have executive sponsorship. And without leadership and support, pathways like this cannot be created and certainly cannot be sustained. And also you have to spend a lot of time, and we did spend a lot of time creating systems, processes and tools. It's just a little sample of a referral pathway that integrates the reception areas in the acute system and the community health. Communication and training are key in achieving anything, because you need to communicate frequently, clearly, within your team, within the other team, between the two teams, and it's an ongoing process. And training. And also you need to monitor the results and be ready, agile and flexible to be able to adjust along the way. If we had surprises, yes, we did, because the workload was quite tremendous. This is a busy day in our dental intake room, and it's not easy to pull out staff and get them to develop a referral pathway. We found the nurses' and doctors' knowledge quite limited in oral health, but also we were excited to see how interested they were to learn. In fact, they were quite excited themselves about the whole program. There was a confusion among definitions. What is a public patient versus what is a public dental patient? And frankly, it took us quite a long time until we got on the same page that these things are not the same thing in terms of eligibility to Medicare funding for care, for example. A surprise was the population demographic spread. And just to give you an example, we had one patient that came to Clayton from Sale, which just shows the lack of access and knowledge of people to their dental clinics. Clinicians have surprises because their understanding of the impact of oncology treatment on oral health was not always up to date, and they found themselves in an ongoing learning curve, day by day and patient by patient. There were roadblocks along the way, and of course, we reached capacity very soon. We naively think initially that we're going to see all the patients that were screened, and this wasn't the case. In about 6 months, we reached the capacity of our appointment book, and then we had to become, very creative in that sense to accommodate these people across other clinicians. We had an initial clinician resistance, because you would imagine if you're a clinician, if you're not exposed frequently to treating complex cases, why would you come out of your comfort zone? We had the interagency communication issues and breakdown in communications in the early stages, which we had to overcome. And we were surprised, and particularly the oncology staff was surprised to learn about the patient's low awareness and interest in their oral health. People were presenting to the nurses thinking that they are okay, they have no problem in their mind, and then the mouth was very different than their perception. Information overload, we were surprised to see how much information these patients receive at the time of diagnosis, how difficult it is for them to actually uptake any advice, particularly to brush their teeth and so on. So we made it work, and we completed the cross-training with the help of Associate Professor Dr. Mina Borromeo and the special needs postgraduate in training that went to oncology department and provided training sessions there. We built the confidence of our clinicians by creating clinical guidelines and tools for them to be able to treat the patients before, during, and after cancer treatment. Everybody mastered the processes. Our administration staff integrated very well with the clinical ones, and we developed a very good patient support resource that was very well received by the oncology nurses because they now can teach the patients how to look after their mouth during and after cancer treatment. This is working because we had an 84% attendance rate. What does that mean? It means that 84%, which is over 150 people, didn't know where the dentist was. So they came to us based on the referral. So therefore, they had timely oral interventions, and therefore their cancer treatment was not delayed, not because of poor oral health for sure. One of the greatest achievements is that the practice nurses have now a new assessment kit. It's an oral health screening tool. It's not too different than the Pearly whites that you saw before on the screen. But what's amazing is that these nurses that have to use about 8 screening tools for anyone who is diagnosed with cancer now took the oral health screening tool, which is quite extraordinary. And now, with the help of the wonderful people from Monash Health, the program is spreading in the region, and these patients will now have better access to oral care. It is also working because the patients have a great experience and improved outcomes. We've done a qualitative evaluation by interviewing some of the patients, and one of the most amazing feedback was related to a patient who really had this oral health as a turnaround, a turning point in his life, which was quite amazing. He said, "The changes to the health of my mouth since going to the dental clinic gave me an up when I was feeling down. Sometimes something good comes out of something bad. I feel like I've been given a second chance." This is also working because the dentist awareness on oral cancer increased. And this is a story of Mr. Anderson, one of Link Health and Community patients, who was very fortunate to see Dr. Jonathan Luck, who has diagnosed him with squamous cell carcinoma of the tongue. And with prompt intervention, he organized referral to the surgeons, and Mr. Anderson had an operation a week later. The surgeons commended Dr. Luck for his prompt intervention and advocacy for the patient's well-being. The next steps are obviously to consolidate our collaborative tools. We need to continue with the ongoing training of our clinicians and the oncology staff. And obviously we need to monitor and adjust our appointment book and have a look what other regional approaches are taken to make sure we work as a team and improve the access of these patients to oral health care. We constantly look for new funding sources, particularly for the private patients who are on low income. And we really want to branch out the referral pathways to other health professionals, because upon dismissal from the hospital, these people lose all their support network, and they are in need of dietitians, occupational therapists, and counselings. And we look forward to develop our regional approach in future and create a network of skilled clinicians that can help these patients. I'm very happy to share with you all the tools we developed from this pathway. This is an achievable and beneficial program for the patients. And also, I would like to end up by saying that let's hope not to leave these people in the too hard basket of dentistry. Thank you very much, and enjoy your afternoon tea.
Well, there you have it, a snapshot of what's going on around the state in oral health. some great programs in place, I'm sure you'll agree, but also many challenges to overcome as well. Thank you to all of our speakers for sharing their stories with us this afternoon. We do have some time before afternoon tea for questions, so if you'd like to ask a question, Alison, Maria, Pearly, Diana, Chan, Shibu, Corey, Kate and Felicia are more than happy to take your questions. So who would like to kick us off, to use a sporting analogy? We've got some time with some people who really know their field, so I think it's worthwhile to grab them while we can. They're very happy to share their expertise. Terrific presentations. Julie.
I've got a question for Felicia. Felicia, it sounded like your program was very personality-based to start off with. It was really dependent on having like-minded people come together. What sort of strategies would you suggest to other people who are interested in implementing a similar program where they didn't have that automatic rapport with their local cancer hospital or treatment centre?
I was just saying this is a hard question, Julie, because as I say, we really identify the opportunity because of the Moorabbin Cancer Centre proximity. But knowing that people come from Sale, for example, nothing stops the nurses and the oncology staff from Moorabbin to actually refer these people to Sale to see the dentist. Why would they have to come to Clayton? And we do have huge, a very wide demographics of the patients who come to Moorabbin Cancer Centre. There are not too many of that kind, so anyone who comes there, could be referred to another centre. Which means that if you uptake the tool, you might not have as many patients as we have, being in a close proximity, but still you will give an opportunity to these people to have timely care. Thank you.
Any other questions? Yes, down the front.
Thank you. My question is to the Plenty Valley team about the schools that they interviewed. Were they disadvantaged schools or just anybody, you can clearly go through the region and pick the disadvantaged schools from others. Just any reflection on that, please?
Thanks for the question. So the schools we went to was in a region of the suburb of in the 10th lowest by the Safer Index. So it was one primary school and one preschool. Yeah, so a very small sample size so far, but we're looking to obviously expand the work.
Next question. Right, one right down the back. So our runner. There you go. Good exercise.
Hi, my name is Dr. Shilpi Ajwani. I'm from Sydney Local Health District, New South Wales. It's been very interesting to see different projects happening in Victoria. My question was for the Pearly White program team. We have been running quite a few programs for aged care facility, and our primary problem in all the programs have been the sustainability. It has been found that if an oral health clinician doesn't visit a facility regularly, despite how much training the staff of those nursing homes and aged care facilities have been provided, it just falls off the rail, and they only call the oral health professional just to get their accreditation through, which is very weak to begin with. So I just wanted to find out from that team whether they encounter the sustainability of the program as an issue.
Now, was that for the Pearly Whites? Yes.
Is there someone from North
Maria?
Richmond here?
Anyone else who represents the Pearly Whites? Ah, yes. We found her. Maria?
Thank you. We did have that sort of sustainability difficulties, but the strategy we use now, we identify one oral health champion in that team, so who can then take it and spread the word. The biggest challenge is high staff turnover. Identifying one champion who's been there for a long time helps us a lot.
Thank you. Any other questions? No? We might break. Although I've got a question. Am I allowed to ask questions? I am a journalist. Smiles for Miles. I have a 4-year-old son. Are you saying that this program is not available everywhere? It sounds like the perfect thing to teach a child such good habits at an early age. So I know I'm not too familiar with the situation as a fairly new mum. Can someone shed some light on what is available for a 4-year-old who's perhaps not in an area where that program's available? Hi.
My name's Rachel. I work on the Smiles for Miles program from DHSV with Diana at EACH. It is a targeted program. We do aim for the most vulnerable areas within the state. That's so that we can most effectively hit those children. We do recommend if you visit your local public dental clinic, they're always willing and welcome to get involved and provide information. There's also other programs involved. The Achievement Program aligns with Smiles for Miles, and the oral health messages are part of their program too. So get your son's childcare to get involved with them, and then you can always contact us and see if you're in our area too.
How long should he be brushing his teeth for? I may as well get as much information as I can while I'm here.
Look, it's really about the technique and making sure he doesn't rush it. Yeah. And it's important that you help him out too, because he probably needs you to support him to make sure he's getting all areas of his mouth.
Fantastic, thank you. Any other questions before we break for a cuppa? We'll leave it at that. Thank you very much. We're going to have afternoon tea now and continue half an hour from now. Perfect, thank you.